and another session with me. And today we are going to talk about all about the emergencies which you are going to came across in your pediatrics. So let's just start with that. What we are going to see in the pediatric emergencies, as you know, that specifically we just start from the newborn, then that is going to be your neonatal resuscitation. And afterwards, it could, if we talk about the resuscitation, then it will be like basic life support and the pediatric advanced life support. So we will talk about that. And then the other besides these emergencies, there's going to be, one emergency is going to be your status epilepticus, and the other will be your status asthmaticus, and then there can be anaphylaxis, and there can be choking, and there can be shock. So these are the basic, the most important emergencies which you are going to came across in your exam also. So we will talk about that. The other emergencies regarding your accident and the poisoning, they are going to be discussed by your other mentor, that is the Dr. Jabira, in another session. So here we are only going to be talking about the main emergencies, while your accidents and your poisonings, that are going to be in your another session. So let's just start with that. And first of all, starting from our newborn, that is going to be your neonatal resuscitation, which is the most important topic of your exam. You will get many questions from these neonatal resuscitation. So, and they will give you one or in another form the same question, but the thing is that you always confuse this neonatal resuscitation. So that's why I have not just added the algorithm, but I have also added the you can see the details, so that you will be able to understand. And one thing I will advise all of you, that please don't ratify these algorithms. Please understand what is the underlying concept behind this step, why we are doing this step in this algorithm, and what will happen if this step is not responding or responding like these. Please don't, because one thing you may, the main mistake you make is that you just ratify that this is the first step, second step, third step, fourth step. You don't know what is the reason behind doing that step. So when you do that, then you become confused in the examination, that this was not the thing in the algorithm, this scenario is somehow different, so how I'm going to proceed further. So there is where you get stuck, and always you make mistakes in this neonatal resuscitation. So I will just advise, please, you can say, I can beg you that please just understand the concept, that if we are doing, then why we are doing, and what are the prerequisites for starting either chest compression or either starting the ventilation. And then you will be able to solve all of these questions without any confusion or the ambiguity. So starting from the neonatal resuscitation, the first step is that you need to brief your team. Obviously, whenever you are going to go into the labor room or the OET, you are going to have a team, whether it's about like the 2-member team or the 3 people or the 4 people. Usually in all the developed countries, like in the UK and all over the Europe, you are going to have a neonatal resuscitation team always. And it usually comprises of one NLD nurse, that is your nurse in the labor room. Then one is going to be your maybe the senior consultant, and the one is another one, maybe the resident or the other attending or someone like that. But always 2 persons are going to be there, usually the NLD nurse, that is the nurse in the labor room and the delivery, and other one is the consultant or whoever the you can say the nominated person for attending these neonatal resuscitation. So at least 2 persons are going to be there, and the more are going to be the good one. So whenever you are there, you have to brief the team, whoever the other person is, that you have to tell them that I will do this and you will do this, whether one will by anticipating the situation, whether it's a high risk delivery or it's a normal delivery. Then you have to check the equipment of the labor room, whether your warmer is working or not, whether your suction is working or not, whether you have the drying sheets available. Then whether your that is the neonatal resuscitator, that is called as the neopop, is working in the working condition or not, whether you have set the oxygen, whether you have set the neopop in the proper settings, and all these things. Because at that time, suppose, because you never know when the baby is going to be delivered and it's a high risk pregnancy, you never know that you have to go up till that your tracheal tube intubation. So you have to prepare accordingly. Then the antenatal counseling. This is the counseling. Basically, you ask for the risk factors, what is the mother is gravida, primary or 2, 3, 4. Then what is the gestational age of the baby? Then are there any risk factors, maternal or the baby, like maternal in the hypertension, diabetes mellitus, any infection, any sepsis, any chorioamnitis, foul smelling discharge, any history of the fever? Then in the baby you ask for any cord around the neck or any IUGR, or there is any hypoxia, fetal decelerations or the accelerations in the fetal heart, something like that. All of these risk factors which you know that. So when you are done with this, briefing and all your preparation in the in the labor room, then the baby has been born. Then what you will do basically, if the baby is otherwise well and you don't need any immediate resuscitation, then you go for the delayed cord clamping, and this is for your 60-second wherever possible. When the baby is okay crying, and then you will just put the baby in the sheets on the mother's on the OT, on the mother's abdomen, and you will allow this delayed cord clamping for the 60-second. But if the baby is happening or the gasping, then you will just cut the cord and you will put the baby on under the warmer. So this is how your birth has been done. And now what are the first step? First step is that you will dry the baby or you will wrap the baby. What does it mean that? You see, if the baby is above 32 weeks of gestation, okay, then you will dry the baby. But for the less than 32 weeks of the gestation, the drying is not recommended. For less than 32 weeks gestation, you need to put the baby wrap the baby in a polythene bag. This is the recommended one. So what you will do, if the baby is above 32 weeks of gestation, then you will dry the baby. And while if the baby is less than 32 weeks gestation, then you will not dry the baby, because it will cause the more hypothermia to the baby, because the baby is premature, the skin is premature. So you are going, rather by drying, you are like making the baby warm. You are, for less than 32 weeks of the baby, by drying, you are putting the baby at further risk of the hypothermia. So that's why you will wrap the baby in a polythene bag, and then you will stimulate the baby, just like on the back and on the palms and your soles of the baby. You will rub it and you will try to stimulate the baby, and then you will keep the baby warm, that is already you have put under the warmer. And along with that, you will change this sheet which you have used for drying the baby, because that has been become wet. And then you will put the baby in another dry sheet, and you will put the cap and the socks and the other clothes, and you will keep the baby warm. So these are the initial steps. Usually you can say, the data says the most of the babies, they, if they have not initially cried and they are apneic or something like that, then they usually cry during these steps. So that usually you do not need to go to the next step. But if after these steps your baby still is not apneic and not crying, not breathing, then what you will do? You will go to the next step. So this is your newborn life support algorithm. This is called as the NLS. This is for the UK. And for the American, it is NRP, Neonatal Resuscitation Program. And there are only a bit of differences, but still we need to, as this is a UK exam, so we have to follow the UK protocols. So this is what I have taken from their UK Resuscitation Council website. So this is, first thing is that you have to do the antenatal counseling, team briefing, and the equipment check. We just talked about that. And then the birth has been done, and the delayed cord clamping, if possible, wherever. If the baby is all right, then you can go for that. Then what you will do, you will, if the baby is not crying, then you will just move the baby to the warmer. You will start the clock or note the time, and you will dry or wrap the baby. You will stimulate and keep warm the baby. Why wrap? What is the wrap? It is written that for the preterm babies who are less than 32 weeks of the baby, place undried in the plastic wrap and the radiant heat. So there are polythene bags, plastic bags, which are available all over in the developed countries, which they use to put the baby who are less than 32 weeks of the age. They just wrap them in those polythene bags, and then they put the baby under the warmer, under the radiant heat. And the inspired oxygen for these babies, if the baby is 28 to 31 weeks, then the range is 21 to 30% oxygen you have to provide. But if the baby is less than 28 weeks, then 30% starting oxygen which you will provide them will be your 30%. Then after you have done these initial steps, then you will assess the baby. And what you will assess their breathing, you will assess their heart rate, you will assess their color and the tone. So and whether they are normal, baby is breathing or not, heart rate is getting better or not, the color is pink or not, and what is the tone, whether the baby is limp or the baby is actively moving. If any of one of them is no, and the baby is not pink or the tone is limp, baby is not breathing, basically this will all happen when the baby is not breathing or the baby is apneic. Then your heart rate will be also not improved. Then what you will do, you will ensure an open airway, and if the baby is preterm, then you can consider the starting the CPAP. And how you will ensure the open airway, you will go with these maneuvers which are called as the put the baby in the neutral position. So how you will maintain the airway, place the infant on their back and just like that, and with the head supported in a neutral position. So let's just see what is the neutral position. This is your basically high over extended neck position, and this is your head over flexed position, while this is basically your neutral position, in which slightly extension and slightly flexion, but in between, not overextended and not over flexed. This is how we put the baby in the neutral position. So first thing is that you have to maintain the neutral position of the baby's head. Second thing is that in floppy infants, pulling the jaw forwards, that is the jaw thrust and the chin lift. So you will slightly put the your finger on the baby's chin, and you will slightly lift the chin along with doing this jaw thrust, which is basically pulling the jaw forwards. And what does this jaw thrust do? Basically this pulls the epiglottis away from the posterior pharyngeal valve wall, and then a tongue away from the palate, and in this way it opens the baby's airway, and it opens and maintain the airway and reduce the mask leak. This is also your question in the TAS paper, in which they have asked about the underlying mechanism of this jaw thrust, and the actual answer is that it pulls the epiglottis away from your posterior pharyngeal valve, and it puts the tongue away from the palate. So this is these thing, putting the baby in the neutral position, head, and then doing the chin lift and the jaw thrust. You are opening the airway so that it becomes maintainable. Then afterward, what you will do, that if still after doing these things baby it's still not gasping, just like that, if after maintaining this open airway by doing these three maneuvers still the baby is gasping or not breathing, then what you will do, that let's just see that. uh, Remember that the routine suctioning of the airway of the non-vigorous infant is likely to delay the initiating ventilation, and it is not recommended. Previously, you must have seen in these this initial steps that dry, suction, stimulate, and keep warm, just like that. But it has now been changed. Remember that there are only now these three steps: dry or wrap, then stimulate and keep warm. They have omitted the suctioning from here. Now they do not recommend the suctioning in the routine. Even if the baby is not crying, they are not asking you to go for the suctioning. Suctioning will only be required when we will see when this suction is required. But they say that the routine suctioning of the airway of non-vigorous, which means these are the floppy infants who are apneic or not breathing, it is not likely to delay the initiating ventilation, and that's why it is not recommended. So what you will do, you have done the initial steps, you have done you have done the airway maneuvers like the chin lift, jaw thrust, and the neutral position, but still the baby is happening and it's and gasping or not breathing. Then what you will do, you will go for the lung inflation by giving them the inflation breath. So if the baby is apneic, gasping, or not breathing effectively, then suction is you can go for the suction at this stage. Is only required if the airway is obstructed due to mucus, vernix, meconium, or the blood clot. So as you are going for the chin lift, jaw thrust, and they're putting the head neutral position, and afterwards still you see that it's not maintainable, then you can check the oral cavity to see any visible obstruction like any mucus, any meconium, any like clot, something like which is visible in the oral cavity. But if there is nothing visible, then you will not go for any suction here. But if there is any these obstruction or any mucus vernix or meconium is visible in the oral cavity, then you will go for this suction before starting the positive pressure ventilation. Because if you have not done this suction and are there anything is going to be there, then baby will aspirate it with the positive pressure ventilation, and then it will become more cumbersome for you. So that's why at this stage, before starting the positive pressure ventilation, you need to see for the suction whether it's required or not, and you have to do it if it is, and confirm to the inspection of the failings after failure to achieve aeration. Then you will start the positive pressure ventilation as soon as possible, ideally within 60 seconds, and you will apply an appropriately fitting face mask with a good mask seal and give the inflation breaths maintaining and the inflation pressure for up to 32 to 3 seconds. And the pressure will be, if it is a term baby, then it will be 30 centimeter of the water, and if it is preterm, then it will be 25 centimeter of the water. So let's just see that. You see here up till now, it approximately 60 seconds. So that you see at the end of the 60 second, within 60 second, you have seen the baby, you have performed the initial step, that is the dry, wrap, stimulate, keep warm. You have maintained the open the airway, chin, lip, jaw thrust, neutral position, and you have also started the positive pressure ventilation, that you have given them the 5 inflation breaths with 30 centimeter of the water with the pressure in the air room, that is a 21% oxygen within the with air. Okay, we have not attached any oxygen here. This is for the term baby. While in the preterm baby, you see, if the baby is preterm, then you will give them the 25 centimeter water pressure while giving these inflation breaths. And you can also apply for the SpO2, that is saturation monitor, and the ECG at this point. And then after giving 5 inflation breaths, what you will do, you will reassess the same thing, color, tone, breathing, and your heart rate. If there no increase in the heart rate, look for the chest movements during the inflation, whether the chest movements are there or not. So let's just see that. After you have given them, you will check the heart rate by stethoscope. So this is the also another important your question, in which they have asked about the what is the most reliable method for checking the heart rate in the newborn during this resuscitation, and the answer is that by the stethoscope. Neither pulses nor umbilical cord sensations, nothing else. This is the stethoscope that is the more appropriate. But if the yeah. Okay. A heart rate that increases within 30 seconds, or a stable heart rate if initially was greater than 100, then adequate ventilation or oxygen has been achieved. So you have given them the 5 inflation breaths, and after that you have checked the heart rate. If it becomes it heart rate that increases within 30 seconds, if initially it was 50 and now it has become 70, it means you have achieved an adequate ventilation or the oxygenation. So you will just continue this ventilation, giving the breaths to the baby until your heart rate becomes greater than 100 and your baby start to have the spontaneous breathing. But if the heart rate is slow or a very slow heart rate, or there is no improvement even after giving the 5 initial breaths, then it means there is continued hypoxia and almost always indicate inadequate ventilation. It means the baby's lungs has not been opened. You are unable to achieve the lung aeration, and that's why the heart rate is not improving. So that's in this case, you have to maintain or you have to go for the other maneuvers to open the lungs of the baby. And along with that, along with heart rate, you have to check for the chest movements, visible chest movements with the inflation. It means your airway is patent, your airway is maintainable, and there is no obstruction, and you have delivered the volume, and it means that the lungs has been opened. If the chest movements are there, then it means adequate ventilation has been achieved. But if there is failure of the chest to move, it indicates any obstruction of the airway or the insufficient inflation pressure to aerate the lungs. It means you have not opened the lungs up till now. In neonatal resuscitation, only one goal is that our goal is not to start the chest compressions, not to start give the adrenaline, not to do anything else. Or the whole concept of the neonatal resuscitation is only one thing, that is your ventilation, which means opening of the lungs. because once the baby has been born, in inside the womb, the baby is not breathing. Baby's lungs are filled with your fluid, all the fluid, and all the gaseous exchange has been occurring through the placenta. After birth, when the baby cry, it creates a negative pressure that is causing the lungs to pop open, and they become inflated, and the gaseous exchange start to occur. But if the baby does not cry after birth and the baby is limp, it means her lungs are still collapsed. They do, and when they are collapsed, it means no gaseous exchange can occur after birth, and you have also cut off the placenta, so there is no other source of the oxygen. So the most important thing is that you have to open the lungs, and anyway, by maintaining the airway and by delivering the inflation breaths and the ventilation breaths, or by passing the ETT, that is the only possible thing you have to do. That just forget about the heart rate, you are not concerned. Even the heart rate is 50 initially, has been born, not breathing, and the heart rate is 40. Usually what we do that in specifically in developing countries, what they do, baby is delivered, and the baby is gasping, or there is no breathing, baby is limp, and the heart rate is 40 beats per minute. What they do, they start they start chest compressions. What is this? That this is not the concept of the neonatal resuscitation. This is the most important mistake which all of you make, specifically in the developing countries, not in the developed countries. Developed countries. So this is totally wrong. This is totally wrong. You have baby is not breathing, but you have started the chest compressions. What you will do, you baby your this until unless you have opened the lungs and you have started to this gaseous exchange by coming in the oxygen and carbon dioxide going out, if there is no way you can improve the heart rate, and there is no way you can improve the cyanosis. What you will do, why the baby does not improve if you do this? Because at 40 heart rate, and there is no breathing, which means there is no oxygenation, there is no oxygen coming inside of the lungs, and there is no gaseous exchange, so you are getting no oxygen inside of your blood. So what you will do, what is the purpose of your CPR? Your purpose of the CPR is that by compressing this your your heart, you are basically trying to pump the blood all over your brain and the important organs. So what you will do, you only have the deoxygenated blood in your inside the baby's a baby's body, because the baby is not getting any oxygen from anywhere. That's why there is cyanosis, because the lungs are not working, they are collapsed. And you start the CPR, so you are only circulating this deoxygenated blood all over the body. What it will do, that it will further aggravate the hypoxia, it will further going, baby will go into the acidosis, and there will be lactate, and ultimately baby is going to die. So this is the most important thing, or you can say the mistake which you make if you are working in a like a developing country. But thing is that this is totally wrong practice. This is not what NRP says, or your NLS says. The thing is that the whole concept of the neonatal resuscitation is opening of the lungs. Just remember one thing, opening of the lungs, inflation of the lungs. If you just work on this concept, and if you solve your questions on this concept, then it will be very easy for you. Only thing in your questions, in your scenarios, you have to see whether the lungs has been opened or not before moving on to chest compressions. Then if the lungs has not been opened, then whatever the option is there, you need to go for that option which is going to open the lungs, whether its heart rate is 30, 40, whatever it is. You have to open the lungs, and after, once you have opened the lungs, you have maintained aeration. If still after that the baby's heart rate is not improving, then you will start the chest compression. Then we will see what are the two indications for starting the chest compression in the neonatal resuscitation. So after you have given the 5 inflation breaths, you check for the heart rate and you check for the chest movements, and then you will proceed accordingly. Whether if the chest movements are there, it means you have achieved the ventilation and you have opened the lungs. But if it is not there, then it means there is any obstruction, or you are not putting enough inflation pressure to aerate the lungs. So what you will do, that there can be then three options can be there. After 5 inflation breaths you have given, then the 3 possibilities can be there. Your chest is moving, your heart rate is also improving. This is the first scenario. So what you will do in this case, it means it is a good sign. Your chest is moving. It means your lungs has been opened and you have done the ventilation and aeration of the lungs. And in response to that, your heart rate is improving. So what you will do, you will just continue the uninterrupted ventilation. You will just keep giving them these ventilation breaths to the baby until the infant begins to breathe adequately and the heart rate is greater than 100 beats per minute. Then you will just stop this ventilation and you will put the baby on the oxygen or whatever, depending upon the situation, or the CPAP or whatever it is, and aim for about 30 breaths per minute with an inflation time of 1 second. Remember that for initial inflation breaths, it is called as the inflation because our whole purpose is to open the lungs, to inflate the lungs. So that's why we have one inflation breath is of about 2 to 3 seconds. That's why it is called as the inflation breath. You have to give them all this pressure to maintain or to open, sorry, inflate the lungs. But after you have opened the lungs, your chest is moving, your heart rate is improving. Now you will give them these ventilation breaths, and these ventilation breath is basically one breath over 1 second. This will, now the time duration will be decreased because initially we just give them this to open the lungs. That's why we took the time of about 2 to 3 seconds for one inflation breath. But now it has been opened. Now we have to just support the baby's breathing. That's why we will give them the ventilation breaths, and that is one ventilation breath over 1 second. Reduce the inflation pressure if the chest is moving well. You will start, if you have started from the 25, then you will reduce it to 20 and then 15, and ultimately you will just stop this ventilation and you will put the baby on the oxygen nasal cannula or the CPAP. And then reassess the heart rate and the breathing at least every 30 seconds. So this was the first scenario when your both chest is also moving and the heart rate is also improving. Our second scenario can be chest is moving, but your heart rate is not improving. Then what you will do? It means your chest is moving, then you just have, it means that you have achieved the opening and the inflation of the lungs, aeration of the lungs. So you just need to keep giving them the ventilation until your heart rate start to improve and it becomes greater than 100 seconds. So you will just continue the ventilation breaths and you will reassess after every 30 seconds. But third scenario can be when your no chest movements with no heart rate response. Then what it will be? Basically, it means when there is no chest movements, it means that you are unable to open the lungs. You are unable to inflate the lungs. It means there is any obstruction or whatever the possibility is there. So you are unable to open. So that's why when your lungs are not open, your heart rate will not improve. At this stage, what you need to do, that you need to do the corrective steps for this ventilation. You will recheck the mask size and the position, that whether the mask is appropriate for the baby, whether it's preterm or the term, and there is no leak from any side. You will again make the proper seal, proper position, and you will make sure that this mask is now, again, you have done it right. After, along with that, you will again the recheck the head position and with a jaw lift or the thrust. Sometimes it happens when we are giving them the ventilation, our position becomes, or the because of the pressure, you just put so much pressure on the baby that the baby's neck become flexed and your airway got obstructed. So in that case, you just because the chest movements we have not been achieved, so that's why we need to do these corrective steps. We need to recheck the mask size, mask position, make sure there is no leaking of the air, seal is good, and and recheck the head position, whether it is in the neutral position or not. If it is not, you need to do again the chin lift and the jaw thrust to make a neutral position. And after you have done these two things, you will repeat 5 inflation breaths. Okay. And after giving these 5 inflation breaths, you will again check the chest movements and the heart rate. If still, if there are chest movements, you have gained the chest movements after these two corrective steps, then what you will do, you will just continue giving them these ventilation breaths, just like these steps, this and this step. You will just continue the ventilation breaths. But still, after doing these two corrective steps, still you are unable to achieve any chest movement, then you will go to the next two steps. As for the suction, this is the inspection of the pharynx and suction under direct vision to remove any obstructant foreign matter if it is present. So you will do the suctioning to if so that if any obstruction is there, then you will just remove it, whether it's meconium, mucus, vernix caseosa or something else. Along with that, you will increase the pressure. If initially, if it is what's 25, then you can move on to 30 centimeter of the water. And if it was initially 30, then you can move on to 35 35 centimeter. So what you will do a gradual increase in the inflation pressure. So you done the mask readjustment and the open air and the this airway positioning, and you give 5 inflation breaths, but the chest movements are still not there. You will then again do the suction, and you will increase the pressure, and then again you will repeat the 5 inflation breaths, and you will again check the chest movements and the heart rate. If after these two steps, then if you get the chest movements, if they are positive, then you will just continue the ventilation breath like all previous steps. But if still after these steps chest movements are still negative, and you are not being able to achieve the chest movements, then what you will do now, you need to go to the alternate airway. This is the point: securing the airway via tracheal tube intubation or the insertion of a laryngeal mask, and 30 seconds of the ventilation through the alternate airway you have to give them. Okay, so now at this stage, after this, still if you are unable to achieve the chest movements, now this is the time you need to put the baby on the alternate airway, and that can be tracheal tube intubation or it can be laryngeal mask. You have to do that. And once they are in process and they are in place, you have intubated the baby. It means now you have, and you will give them the breaths. It means that now you have definitely opened the these lungs of the baby. So after you have intubated, you will check again the chest movements and the heart rate. And if the chest movements are there, it means you have opened the lung, you have inflated the lung through this laryngeal mask or the tracheal tube. And now you will give them the 30 seconds of the ventilation through this alternate airway. And after again, you will check the heart rate. If your heart rate is above 60, it means your lungs are open and your heart rate is improving, then you will just continue giving them the ventilation breaths. But if still after giving this intubation, opening the lungs and doing this 30 second of the ventilation, your heart rate is still less than 60 beats per minute. Now this is the time you need to start the CPR. This is, you see how many steps we have done to come up till CPR. So this is how, this is just on the, you can say, bottom of the hierarchy. The top one is all your going to be your ventilation, inflation, ventilation, positive pressure ventilation, alternate airway, suction, pressure increase, and each and everything. There is a long way down when it comes to the CPR. We will talk about again in the next step, that when we are going to talk about the CPR, start the CPR. And only one thing is you need to remember: without adequate lung aeration, chest compressions will be ineffective. So, where the heart rate remains very slow, first confirm effective ventilation through observed chest movements before progressing to the chest movements. If your chest is not moving, baby is in apnea, baby is not breathing, and you just start the CPR, there is no use of that. Rather, you are damaging the baby. This is the most important mistake which you made in your daily routine. So this is where we were, if we talked about all these steps. If chest is not moving, you will go for the chest mask and the head and jaw reposition and the two-person support. Usually with one hand, the mask may become leak out from somewhere. So if it is not possible for you to hold the mask with one hand, then you can use the two hands and you will ask someone else to give them the pressure, give them the, like squeeze the bag or give them the breaths. Along with consider suction, laryngeal mask, and the tracheal tube, and repeat the inflation breaths and consider increasing the inflation pressure. We have done all these things. That's why I have added all this theory, so that because it becomes difficult to memorize or maybe the understand from this algorithm, because here they have just added the main things. That's why I've added all this theory, so that it become easy for you that what is the next step, how we are proceeding here. And then it will be very easy for you to understand and memorize these steps. So now we have come to the chest compression. So what are the basically two indications, or you can say the conditions for starting the chest compressions? When your heart rate is less than 60 beats per minute, despite giving them the 30 seconds of the effective lung, not inflation. Here, sorry, this is ventilation. Inflation is something else and ventilation is something else. This is, I think, this is my writing mistake. This is typing mistake. Heart rate of less than 60 beats per minute, despite giving them off 30 seconds of the effective lung ventilation is being done, and preferably through an alternate route, that is alternate airway, that is your laryngeal mask or the tracheal tube intubation. Usually, this is done. Up till this stage, we have done this alternate airway, and